Thank you all for staying back the last day, the last session, the last lecture. My topic is closed claim studies in obstetrics. No conflict of interest to disclose in relation to this presentation. The objectives of the talk will be to describe the ASA closed claims project in brief. I'll then move on to the obstetric claims database, and then in detail review the Joe Davies publication in Anesthesiology from 2009, and then finally provide you with the latest numerical update of the claims data in obstetrics up to 2010. That sounds better. That sounds better. Okay. So the ASA closed claims database, the goals are to identify major areas of loss in anesthesiology and identify patterns of injury. At the same time, provide strategies for prevention of injury and improve patient safety. The other concern was that the insurance, malpractice insurance for anesthesiologists was very high, and they wanted to look at ways and means to reduce it. The closed claims project is located at the University of Washington in Seattle, where Dr. Cheney took the reins of the project in the early years, and it still continues to be housed there. So the methods they use at the closed claims project are to do an in-depth investigation of the closed insurance claims resulting from anesthetic mishaps. And up to 2010, which is the latest numerical update, there have been 9,536 claims. The insurance companies are contacted every year, and then a group of volunteer practicing anesthesiologist reviewers complete a detailed data form and a summary for each claim from these insurance claim files. The data forms and the summaries are then reviewed by members of the closed claim committee and entered in the database. Most cases are collected from mishaps that have resulted in lawsuits. And this is done on a continuous basis, and there is extensive information in the database. The database finally will summarize each case, and that summary includes patient information, surgical procedure and positioning, pre-anesthetic evaluation, anesthetic technique, any events that led to the injury or the claim, the type and severity of the injury, the outcome of the litigation, and then any physician evaluations. As I said earlier, the database now has 9,536 files. 14% of those claims are related to obstetric care. Within that 14%, 60% are related to cesarean section and 38% to vaginal delivery. 35 US liability insurance carriers provide this information. So just some definitions. Medical malpractice claim is defined as the demand for financial compensation for an injury resulting from medical care. And this could involve inadequate standard of care and or inadequate standard of conduct. A closed claim, on the other hand, is a medical claim that has been either dropped or settled between the parties involved or has been resolved in the courts. No further payment or treatment is expected. Very appropriately, almost now 85 years ago, Haggard said, and I quote, "The position of a woman in any civilization is an index of the advancement of that civilization, and that the position of a woman is gauged best by the care given to her at the birth of her child." So we move on to the obstetric anesthesia database in the closed claims project. As you know, obstetric carries high medical legal risk, and that prompted the American College of OBGYN to conduct a survey on professional liability that was published in 2006. 89% of the respondents said that they had been sued at some point. There were 2.6 claims per obstetrician, and it involved 31% of newborn brain injury and 16% had neonatal death. In Massachusetts, when they surveyed their OBGYNs, 39% of them had liability payments. So malpractice insurance premiums are paid by the obstetricians to cover these lawsuits for birth-related cerebral palsy. It's unclear though, and this was an article by Chadwick from 1991, whether the increased liability of obstetricians would extend to OB anesthesiologists. So that prompted their group, the Chadwick group, to review the obstetric anesthesia malpractice claims before 1990. And they found newborn death and newborn brain damage to be the case in 29% of the claims, and maternal death in 22% of the claims. And this is, again, I repeat, from the 1991 published data. But over the last 2 decades, numerous changes have occurred, both in the practice of anesthesiology and in obstetric anesthesia. So we know from what has been presented here and from elsewhere that general anesthesia incidence for elective cesarean section has dropped dramatically. Labor analgesia using epidurals has gone up substantially, and there is a recognition now that only a minority of cases of newborn encephalopathy are related to intrapartum hypoxia. So this prompted Joe Davies, who again works in University of Washington, to look at the data from after 1990 up to 2003, and that was published in the 2009 anesthesiology paper, to look if the liability profile has changed from before 1990 to the one after 1990. So what did they find? I'll be discussing this paper in detail because that is the most updated information we have from the closed claim database in terms of published information. So they had 7,328 cases till 2003. And the database actually started in 1970. So over almost 33 years, that's the number of claims that were there. Obstetric procedures that occurred from 1990 to 2003 were included in this study as claims from, and they labeled it as 1990 or later, and they were 426 claims. Whereas the Chadwick paper, which had the pre-1990 data, had 190 obstetric claims. So what are the characteristics of the claims in the Davies paper? So they looked at proportion of perioperative claims, and it was essentially similar pre-1990 and 1990 or later, 12 and 13%. The mode of delivery was cesarean section, 67% before 1990, dropped to 58%. So some decrease. Vaginal delivery increased from 33% to 42%. What about the type of anesthetic? Regional anesthesia went up from 65 to 80%, and general anesthesia dropped from 33 to 17%. Respiratory events, there was a significant change, 24% respiratory damaging events before 1990, and then dropped to 4% after 1990. So there was a substantial difference there. Aspiration of stomach contents dropped from 4% to less than 1%. Esophageal intubation dropped from 4% to 0%, and that kind of ties in with the use of capnography in anesthesia. Similarly, inadequate oxygenation and ventilation dropped from 5% to 1%, and that, again, probably with the advent of pulse oximetry, helped. However, difficult intubation did drop, but didn't drop significantly. It was 5% pre-1990, and then it was only 3%, so a marginal difference after 1990. The standard of care was also looked at, and it improved from 39% substandard care pre-1990, dropped to 22% substandard care. Payments were made in 58% of the claims before and 42% after 1990. And the median payment amount also dropped from $455,000 to $222,000, even though the range was essentially similar. What about the pattern of injury in these claims? And again, this information is from the Davies paper of 2009. So they looked at proportion of maternal deaths, maternal brain damage, newborn deaths, and newborn brain damage. And if you look at this slide, there was a significant drop in maternal deaths, some drop in maternal brain damage, and then a drop in newborn brain damage and newborn death. On the other hand, there was an increase in maternal nerve injury and back pain. The most common injuries that they found in this paper were 21% both for maternal nerve injury and newborn death and newborn brain damage. Minor maternal injuries included headache and back pain. So what were the liability characteristics associated with these injuries? Payment by all parties is shown in the white bar. And for maternal death and maternal brain damage, that amount was about $1,100,000. For newborn death and brain damage, that amount was $892,500. However, payment on behalf of the anesthesiologist was 60% in the maternal death brain damage group and only 21% in the newborn death brain damage group. And that is significant because it had dropped from the previous data which predated 1990. Again, looking at payment by all parties shown in white was $126,000 in maternal nerve injury and $25,000 in maternal minor injuries. And the payment on behalf of the anesthesiologist is shown in the hatched bars below. So moving on to when they looked at the major complications, starting with newborn death and newborn brain damage. What are the factors associated with newborn death and brain damage in this survey? Non-reassuring fetal heart tracing and urgent and emergent C-section were about 71%. Possible anesthesia contribution to this claim was 22%, which had dropped from before. And within this section, anesthesia delay was responsible for 55% of the claims for newborn death and brain damage. Poor communication between obstetrician and anesthesia care team was 35%, and substandard anesthesia care was 82%. Other factors involved were maternal coexisting condition, 15%, umbilical cord problems, 12%, and then 9% each, both for uterine rupture and abnormal placentation. And within uterine rupture, they had 8 cases, and out of those 8, 6 of them actually were vaginal births after cesarean section. So to summarize the results so far, in the claims after 1990, payment was made on behalf of anesthesiologists, only 21% of the newborn damage claims compared to 60% still in the maternal death and brain damage claims. Payment in both groups was associated with an anesthesia contribution to injury and substandard anesthesia care. There was increased proportion of delays in anesthetic care in 11 out of 22%, 11 out of 20 patients. That accounts for the 55% you saw in the graph earlier. And out of those 11 patients, for 6 patients, the anesthesiologist was not in the hospital. And in 3 out of those 11 patients, there was prolonged attempt to administer regional anesthesia without fetal monitoring. They also found that there was increased proportion of poor communication between the OB and the anesthesia teams regarding the urgency of C-sections. Some of the claims in this group included difficult intubation causing maternal hypoxia leading to newborn death or brain damage, and profound hypotension after neuraxial block. What about nerve injury? Radiculopathy was part of this claim they found, and nerve injury actually was the leading maternal injury in claims after 1990, presumably because regional anesthesia use had increased. 54% of those nerve injuries were radiculopathies, and actually 18% had spinal cord injury. Within that 18%, 11% had paraplegia and 7% had no paraplegia. And the causes, when they compared, they found that the 21% nerve injury claims had gone up from the 16% before 1990. Most of these, luckily, most of these claims, the nerve injury claims were temporary, injuries were temporary and were non-disabling, even though there were claims associated with them. And most were associated with vaginal delivery. Amongst the paraplegia group in the spinal cord injury claims, there were 10 patients, and there was, the distribution was epidural hematoma in 4, epidural abscess in 4, direct injection into the spinal cord in 2, and then anterior spinal artery syndrome in 1 of the patients. Majority were shown to have had appropriate care, and anesthesia provider payment actually was less than 1/3 of the claims. Next complication they looked at was maternal death and maternal brain damage. And they found that it was associated with 28 patients in the general anesthesia group, 41 patients in the regional group. And within this section, high neuraxial block was responsible for the majority of the claims. Of course, they were in the regional anesthesia group, and it was 37% of those 41 patients. The next slide shows that those 37% claims involved 15 patients. 12 of them were for epidurals, 3 were for spinal anesthesia, and 80% of the claims, there was a delay in recognition and treatment of the sequelae of high block. Luckily, there were no claims related to intravascular injection of local anesthetic in this 13-year period, 1990 to 2003, and probably from the increased awareness of local anesthetic toxicity. Way back in 1984, 0.75% bupivacaine was withdrawn for epidural use by the FDA, and the understanding that it's better to use fractionated doses sequentially for epidural injection and to aspirate before each injection. Other prevention strategies mentioned in the paper included availability of adequate resuscitation equipment in labor and delivery. The staff should familiarize themselves with the location of the cord cart. The cord cart should obviously have appropriate equipment and drugs, and that epidural carts actually should have airway equipment and emergency drugs available. Going back to maternal death and brain damage, the next important factor they looked at was maternal hemorrhage, and there were 11 patients with maternal hemorrhage, and they found in their analysis that 10 of those, the anesthesia team were unable to keep up with the blood loss, and there was inadequate fluid replacement in the 11th patient. The causes included subcapsular hepatic bleeding, placenta previa, placenta accreta, and uterine rupture. Difficult intubation was responsible for 1/4 of the patients out of the general anesthesia group. There were 7 patients, and interestingly, even though the data was till 2003, the difficult intubation stopped in 1998, and probably because LMA was now more routinely available in the United States as a bridge to securing the airway or as a means to oxygenate and ventilate the patient. 6 of these 7 cases the difficulties were noticed at induction of general anesthesia. They usually involved multiple attempts. There was progressive difficulty with ventilation noted in these patients. And in 2 of these claims, general anesthesia was induced after a failed regional block. The practice guidelines in obstetric anesthesia came out in 2006, probably need some updating. And they said that the L&D units should have personnel and equipment readily available to manage airway emergencies. Anesthesiologists should have a pre-formulated strategy, and if tracheal intubation fails, then use face mask, and then if that is not helpful, in the presence of cricoid pressure, may have to place an LMA. If ventilation is difficult or waking the patient up is not possible, you should consider a surgical airway and consider it early. Other recommendations are recognition of patients with difficult airway in your pre-anesthetic evaluation on the labor deck, and establish a neuraxial block early. All anesthesia providers, especially obstetric anesthesia providers, should update themselves with the algorithm from the ASA, and a fresh iteration of the algorithm came out earlier this year. You should take a look at it and make sure that you have additional skilled providers available at especially induction of anesthesia and possibly even at emergence, given the data that we have now, both from United Kingdom and from Michigan. So just to recap quickly what we said, I know there is a lot of information and a lot of numbers. So just a quick recap, obstetric anesthesia claims contributed to 12 to 13% of perioperative claims in both time periods before and after 1990. Given the increased rate of cesarean delivery, there is a smaller fraction of claims now in the post-1990 group involving cesarean delivery, 58% versus 67%. Compared to pre-1990, there was an increase noticed in the use of epidural analgesia for labor and maternal nerve injury possibly related to that, and maternal back pain. Similarly, there was a decrease in maternal death claims, which is good news, neonatal death and brain damage claims, and proportion of claims with substandard care. Interestingly, payments were also lower, 42 versus 58%, and payment amount, the median amount, had decreased as well. So 2 weeks ago, I sent a query to the project database at the University of Washington to see if they could provide some update that I could present here. And they were very forthcoming, and they were very helpful, and they provided me with some information that I'm going to share. And it is essentially not a detailed analysis, but at the same time, it gives you some insight into the numbers when they have the database up to 2010. So we have more information after 2003 that is available in these numerical data now. So the project started in 1970, and in the 40 years, there are 9,536 claims. But in the period after 1990, which the closed claim project people want to focus on, is 4,709 total claims, because they feel that the standard of care before 1990 was not representative of modern care. Out of those 4,709 claims, obstetric claims account for 640, so that you are left with 4,069 claims for non-obstetric reasons. Within this 640 claims, 14%, within these 640 claims, which is 14% of the total after 1990, neuraxial anesthesia contributes to 76% claims. General anesthesia has further dropped to 19%. Cesarean section is actually similar, 60%. It has gone up from the Davies paper of 58%. Vaginal delivery, 38%. Even though the total doesn't add up, they had missing information on some claims. Within this section of claims, maternal nerve injury accounted for 19% of the claims. Neonatal brain injury further dropped 16%. Maternal deaths, 15%. Headache and back pain, still there, but at a lower level, 11 and 10%. What about the payment amount? There is lower incidence of obstetric claims in terms of payments compared to the non-obstetric claims, 45%. And the lower payment incidence in OB anesthesia, they think, is because the claims against anesthesiologists are there, but they are not related necessarily to anesthesia causation or anesthesia negligence. The median payment amount for obstetric payment was higher than the non-obstetric claims, being $398,000 versus $254,000. even though the size of median payments is high in both groups, they feel that the obstetric claims are probably higher due to permanent maternal brain damage, and these moms are young when the injury occurs. Permanent maternal nerve damage, again, it happens at a younger age. The younger age of the neonates, and the need for lifetime care that is needed for both these categories. So the payment amounts for that reason are higher, but the incidence is lower. I would like to summarize here. So we went over the closed claims project. We talked about the OB database. We talked about Joe Davies' paper and a numerical update on the current information. On that note, I'd like to thank you for your attention. I hope you are having a good time in San Francisco, or can have a good time now.